Can I just remind members that we're going to do a photo of us for the annual report. We're going to do it very right. Could all the members go just outside the door and we're going to have a quick group photo. Thank you for your indulgence. Good afternoon, everyone. Welcome to the Health Scrutiny Committee. Today, 24th of March 2026, and welcome to all of the members here and to our guests. As ever, feel free to take pictures and use social media during the meeting, but please turn your phones to silent or vibrate. The meeting will be live streamed and a recording will be available to watch later via the Council's website. There's no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting and we will leave via the side doors and use the fire escape next to the kitchen. The assembly point is the car park. The committee, as always, is joined by Jess Slater, the Chief Executive of Healthwatch. Welcome. Healthwatch Cambridgeshire and Peterborough. Healthwatch is not being scrutinised and has a standing invitation to contribute to all our health scrutiny sessions. During our preparation for today's meeting, we agreed to revise the order of the business slightly to take the recommendations tracker first, to take a particular issue about NWAFT, which is contained within that. First, though, we do changes to the committee membership. We're invited to note that Councillor Peter Fane, on my right, was appointed as the vice chair of the committee. We did know that last time, but it needed to be confirmed by full council, but that was confirmed in December. Welcome, Peter, and already enjoying working with you. And Councillor Stefan Fisher joined the committee on the 3rd of December, succeeding Councillor Andy Osborne. Councillor Osborne was appointed as a substitute member of the committee. So welcome to Councillor Fisher. Item 2 is apologies for absence and declarations of interest. Rachenda, apologies for absence, please.
Thank you, Chair. Apologies have been received from Councillor Pitt.
Any others that anyone wants to pass on? Okay, and does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? None. Item 3, the minutes of our meeting on the 3rd of December, which are at pages 5 to 18 of your agenda pack. The committee is asked to approve the minutes as an accurate record. Are there any objections to that? No, there are not, so they are agreed, and I'm now going to sign them. Next, health scrutiny recommendations tracker. So this is the item brought forward. Can I invite Councillor Sanderson to come to the table in front of him, ready for his contribution? But this is on all of the recommendations, not just any specific one. So I will ask Rachenda to introduce the item, please.
Thank you, Chair. As the committee will know, the recommendations tracker is a standing item and it provides an update on the responses that have been received to the committee's recommendations. Just to make you aware, we have received more responses from the Integrated Care Board since the papers were published. So we will review those and get those out to committee members and we'll include updates next time, just for completeness for the record. Thank you, Chair.
Thank you. One that we're going to pull out at the start is the committee is the issue of electronic patient records at NWAFT, following concerns that were shared at our previous meeting by the Integrated Care Board. NWAFT at the moment uses an analog rather than a digital approach, has made their intention to move to fully electronic patient records in the line with the other trusts within the county. And rather than trying to rush a scrutiny item today, we thought we would write to them, ask them for an update on that. But the update only says they have good intentions. I'm sorry, I apologise to them if that sounds unfair, and doesn't record any progress towards actually achieving electronic patient records. There have been a number of exchanges between Councillor Sanderson, who is the County Council's governor representative on NWAFT and Councillor Fane and myself. And together we decided that although we're not scrutinising NWAFT today, that we would have an exchange on that so that our concerns go on the record. And it may be, we'll see what members say, but it may be that we do agree to advance that and to put it on as a formal scrutiny item going forward. Having introduced in that way, I'd like Councillor Sanderson to address the meeting.
Well, thank you very much, Chair. Good afternoon, members. As you accurately said, NWAFT, so that's Hinchinbrook Hospital, Peterborough City Hospital and Stamford, are still using analogue records. I think they're the only NHS trust in the region that doesn't have electronic patient records. And also, Addenbrooke's, Cambridge University hospitals have EPR, and patients that go between the two hospitals are often confused and don't understand why they can use it for one trust and not for the other. And it is, I think, one of the biggest risks that the trust is carrying at the moment. I think they would appreciate some discussion with the County Council just on a potential way forward. I know they'll have to engage with NHS England as well. But I think as well as scrutinising, it might be useful if somebody from this council could sit down with a representative from NWAFT and just discuss how we might assist them if we possibly can. I mean, local authorities do carry a lot of data themselves, don't they? And they try to integrate with social care and with the health service. So they do appear to be struggling with this issue. If that you think is a potential way ahead, more than happy to do the introductions. Thank you, Chair.
Just on that point about sitting down with them, it sounds sensible, but I know the Executive Director has got a short comment on that.
Yeah, thank you, Chair. I'm more than happy to extend the conversation and meet with colleagues from NWAFT. I think it would be useful to also invite partners from the Integrated Care Board, from the Central East Integrated Care Board, to that meeting. I think it's important that we're all cited on that, because there is a broader piece of work around electronic patient care records than just social care that I think we just need to be mindful of and understand the challenges that NWAFT may or may not be facing in terms of meeting that requirement.
Thanks. I'll sum up in a moment, but I'll just give an opportunity for any other members, having heard that, to comment if any of you does have a comment. Councillor Martin.
Thank you very much, Chair. I think this is definitely a topic that we should be looking at as a committee more broadly. And from my point of view, it's more to do with the new hospitals programme, which is coming forward at Hinchinbrook Hospital, because one of the criteria that NWAFT need to meet to be able to continue with the new hospital programme is getting a digital maturity level high enough to reach that point. So currently they're on a 0 or 1, and they need to be at least a 5 on the scale. I can't remember the acronym for the scale off the top of my head, but there needs to be significant progress. And if we want a new hospital in our area, in our county, we need to make sure that we're pushing on that. I know there's a lot of work going on. I've spoken to Hannah Coffey personally about it, but I think it is something for us to bring here so we can make sure that we have an overview of what's going on, because that project is critical to Cambridgeshire.
Thank you for that comment. Any other member comments? Councillor Sanderson again.
Thank you, Chair. If I could just come back in, I may be a bit naive here, but of course our partners in the district and city council hold a lot of data on the same people that will use the hospital if they're claiming benefits, council tax, etc. I don't know if there's something that we can do with them, with the other tiers of local government, to try and integrate something. But I agree with Councillor Martin that, as we know, Hinchinbrook have got plans to expand, and if this is part of that project, then I think it's even more vital that we work with them and see if we can come up with a solution. Thank you.
I don't think I am seeing another hand. Councillor Dr. Noaz.
Thank you. It's just a general query. This data, where is it stored? Who do we use for analytics, and what sort of security is there? Thank you.
Obviously, that's for NWAFT to answer, but obviously we've also got knowledge at the table. Sally?
Apologies, I was going to say nearly exactly the same thing. NWAF would have the details on that. Unfortunately, we do have a population health management steering group that I chair, which is all around how we can come together as a system on our data and analytics to gain the intelligence that we need to drive action. But in terms of how it's all stored in the background and sort of the intricacies of their individual systems, I can't answer. So we can if we sit down with them, they would be able to answer that.
Yeah, thank you, Chair. My question arises from the concern that we, or certainly I had, about the NHS data being handled by Palantir, which I and a large section of the public had concerns with as far as the national security is concerned, given that Palantir is a CIA-financed company, and on their website, certainly at the time that I looked at it, were boasting successes in the Ukraine war theatre and the Middle East. So hence my concerns. And I think ICB were going to come back, according to the minutes, saying that they will speak to their national colleagues and report back to us. That was on the meeting of 3rd of December, Chair. Is there any update?
Thank you. It's an important point. I will ask in a moment Rashenda to comment, but I want to deal with the NWAFT issue first, if I may, but then I'll immediately go to her. Anyone else on NWAFT? Okay, in summing up, what I'll say, I was disappointed by NWAF's response, so I'll put that on the record. I think having taken the initiative as a county council to ask them about progress, it was disappointing to see how little evidence there was of progress in the note that they sent back to us. I also think it's really important part of our health scrutiny that when an individual member, be it a governor member or another member, brings forward a concern about this, that we really listen to it. And so I'm pleased that Councillor Sanderson has raised the issue and has had the opportunity to raise his concerns today. I concur with Councillor Martin that this could actually potentially impede the development of a new hospital at Hinchinbrook. I think that's a very fair concern for us to raise. And both he, Councillor Sanderson and myself have explicitly said that we need to put this on a future agenda. So I'm asking members now, can we agree that we add this to a future agenda? We'll leave to Rashenda and outside the meeting exactly when, but can we agree that? Can I see nods if you're happy? Anyone unhappy? No, that's agreed. Also on the recommendations tracker is the item raised by Councillor Dr. Nawaz. Rashenda, could you comment on whether we've had the appropriate response as of yet?
Thank you, Chair. Yeah, Councillor Dr. Nawaz is absolutely right. That was one of the recommendations that the committee made. I can't say off the top of my head whether we've had that, because as I say, we have had responses, some additional responses that have come in from the Integrated Care Board in the last week, and I haven't had a chance to work through those yet. But I have spoken to Jan Thomas's office, and I know it was something that they were progressing. So I will update you on that once I've gone through the responses and let you know.
And I'll just comment, there's quite a lot of you having to chase and replies not received. It's great that you do the chase thing, but I think some of these replies should come without needing to be chased. I will just balance that comment with the progress check we got from the ICB on learning disabilities health checks, which I thought was brilliant, and that they'd really listened to the comments made by members here and acted upon them. So there's some good examples of very good practice out there, but I think that there are examples where it's taking too long for the information to be received by us. And as far as I'm aware, that includes the point made by Councillor Dr. Nawaz, and Councillor Garvey also was very strong on that issue at the last meeting. So we'll chase that unless, unbeknownst to us, a reply has been received. Anything else on the recommendations tracker? Councillor Kane.
Just wanted to come in because Councillor Sanderson wanted to do a follow-up question. So just wanted to about can we confirm that we will be meeting with NWA?
I've said add to the scrutiny programme. I suppose an alternative might be that we ask for a member level meeting, but I think taking into account what Patrick said, I think what Councillor Sanderson wanted, and please feel free to come back, was for senior officers to get together. Have I understood that correctly?
Thank you, Chair. Yes, I think it would be useful if our officer team could meet with MWAFT at their earliest convenience and discuss this. And I'm happy to attend if that's thought to be appropriate. Thank you.
Councillor Kane's happy with that, as am I. I'll leave to your discretion, Patrick, whether Councillor Sanderson is there. Anything else on the recommendations tracker? Councillor Dr. Nuez.
Thank you. I have a couple of other points which I couldn't see. Perhaps Richanda did register them and I missed them. Two of the points were, one was about the men's health strategy, which at the last meeting on 3rd of December, I think ICB said that it was too new and they hadn't had the time to digest that, but would come back to us. And the third point, Chair, is about the dentistry school at the Anglo-Ruskin University in Peterborough. We haven't heard anything on that either. So could we possibly chase these up, please, rather than let them fizzle out?
I do promise everyone that Richenda doesn't let anything fizzle out. She's very assiduous at the tracker, but it's completely proper for members to raise their concerns at the meeting. And I will again just let Richenda briefly answer Councillor Dr. Nuez.
Yeah, absolutely. I will check those, and if we haven't had responses on them, I'll pick it up.
It also means it goes in the minutes. There's a very clear record that this is a priority as far as members are concerned. Okay, can we note the recommendations tracker, having read all of that? Everyone happy? Good, good. Thank you to Councillor Sanderson. We understand if you don't stay for the whole meeting, but if you do, you'll enjoy it. We now move to item 4, Children's Autism Health Services in Cambridgeshire. The report is at pages 19 to 28. To our guests, please do join us at the table in front of you. And those guests are Pam Green, the Integrated Care Board Director of Neighbourhood Health, Place and Partnerships for Cambridgeshire and Peterborough, Catherine Goose, Head of Children and Young People's Mental Health at the ICB, John Peabody, the Director for Children and Young People's Health Services at Cambridge Community Services NHS Trust, and Carolyn Simmons, the Operations Director for Children, Young People and Families Director for Cambridgeshire and Peterborough NHS Foundation Trust. So apologies that it's starting slightly later, as you saw from the agenda change. We're extremely glad that you're joining us. Thank you very much for doing so. I will begin by asking Pam and her colleagues to briefly introduce their report. I will then ask Jess Slater if there's anything she wants to add before we move on to member questions. I know it sounds a little bit discourteous, but if you keep your introduction nice and short, it gives us more chance to talk with you and have a proper dialogue. So I am grateful for that. Please.
Yeah, and thank you very much for inviting us here for Scrutiny. I'm Pam Green, as introduced, and I've the local recently appointed neighbourhood director, so we'll be representing the ICB in these forums going forward, and I think you were informed of that at the last Scrutiny committee. I will turn to my colleagues very shortly, but I would like just to give you a very quick update on the restructure of the ICBs, just so that you're aware. We have gone into restructuring in earnest now and are interviewing our staff So whilst I recognised and I have chased some of the items that you have addressed in the opening of the meeting, we have to restructure 1,700 staff into a 50% smaller organisation and need to get that done in the next couple of weeks, owing to national asks to bring together 3 ICBs into one. So please, if we have dropped behind with a little something during the last few weeks, it may well be owing to that huge burden where we must be supporting our staff to, of course, go through that process. It is very, very difficult for them personally and professionally. Colleagues that sit with us are affected by that, so please understand that when we're interacting with you. It doesn't mean that we're not here to do our job. We're obviously here to do our job, and the outcomes and well-being and care of our population that we commission for is absolutely uppermost in everything that we do. But we are balancing that huge HR and legal process that we're going through. And I know that it will come for local authorities when local government reform it starts as well, and we will be supportive of yourselves and your staff as well when that happens. So I'll turn to my colleagues now for the introduction, but thank you for giving us the time to come here to talk about this really important item.
Thank you, Chair. I am Catherine Goose, Head of Children and Young People's Mental Health.
And it's it's quite difficult sometimes to hear. The way to actually deal with it is to pick up the machine and move it nearer you, and then we will hear you better. Sorry about that.
Thank you. Thank you for the tip. Hello, everybody. I am Catherine Goose. I'm Head of Children and Young People's Mental Health Commissioning and Transformation at the ICB. Thank you for this opportunity to come and present our paper around children's autism health services. Just for some context, although the request was around children's autism services, the paper's written in the context around autism and ADHD because of the way services are delivered and the needs of children and young people. Autism and ADHD is really intrinsically linked, and therefore this paper is talking about children with either or both of those particular needs. So as you will have seen through the paper, it talks through some national context. There's been a lot of work nationally around the autism and learner disabilities agenda, and around the ask was around waiting times. As you'll have seen in the paper, there has been a significant national increase in demand for autism and ADHD services, both all age, so children and adults. And one of the major challenges around the demand versus the capacity within services to meet that demand. This is something we have seen in our local services across, and there is data within the paper that demonstrates that increased demand for and therefore associated waiting times for children and young people. It's also noted in the paper, particularly in section 2, around the volatility of the data. So often referrals will come in within children, they sit within their school. So often there's peaks and troughs that align to school times. So we see quite a lot of peaks and troughs across demand, which often makes service management quite challenging. It also notes in the paper the waiting times, and we are very acknowledged that there are a large number of children who are waiting a long time for these waits. To address these, we are taking a number of actions, which again are detailed in the paper. We have the way that our services are commissioned and delivered across Cambridgeshire. So the preschool and primary school is delivered by Cambridgeshire Community Services, and John will be able to talk more about the work that they are doing specifically for those young people. And for our secondary school age children up to 18, that's delivered by Cambridge and Peterborough NHS Foundation Trust. And Caroline's here to represent the services who support those children, young people. There has been some national money that's flown through NHS England lately, because there is this national acknowledgement around the long waits that people are waiting, particularly for these services. So there's some short-term funding that's being put within both of the providers who are represented here to help them address that. And there's detail in the paper around some of the work that's being undertaken currently to do that. That work is happening now, so therefore the outcomes and the very specifics will be limited to talk about today because it's a live piece of work that's happening, but that's to be done within this financial year. So we've only got a week or so left. In terms of work forward in the ICB, so we are, as Pam has noted, we're moving to an integrated care board across Central East, and we see a real opportunity to understand and learn also from our colleagues across Bedfordshire, Luton, Milton Keynes and Hertfordshire around how they're delivering their pathways for children and young people. I feel that we can learn from there and see how we can build on maybe some good practice around there. In terms of moving forward, there's work that's happening specifically around ADHD at the moment, because again, that's for our area is a real big focus, and there's an awful lot of people waiting, particularly in the adult space around that. So again, we're doing some work around developing provider frameworks to help us think about how the breadth of providers out there to support children and young people. We've also got a long-term improvement plan that's also been working to support children and young people. That's based on the National Autism Strategy that came out 21, which was for 2021 to 2026. And there's a number of work streams in there around early identification support. I think one of the other things that in the paper as well that's really quite important to point out, and this is particularly relevant for the primary and preschool, is that the current provision is around community paediatricians. They're the workforce that are predominantly doing these assessments. They do a huge range of work for children and young people. They do a lot of work for our children and young people who have complex health needs, children in care who may need health assessments. And again, that makes it quite challenging in terms of managing the workload of that particular workforce because the demand coming in varies. So it's not that there's particular workforce currently providing that, just the assessment process.
Can I ask you to bring your comments to a close?
Yeah, absolutely. So I think predominantly we just want to acknowledge, and in the paper, that the demand and the complexity of our children and young people is changing and is increasing, and that is the main reason that's having an impact on our waiting times to support these children and young people.
Thank you so much. We're going to have 3 rounds of questioning. First, looking at meeting demand and any new or innovative approaches which may assist that. The second will look at the all-age autism strategy and performance in relation to that. And then I will ask for a final round of questions for any that have been provoked by the discussion, but not yet asked from members. Firstly, on meeting demand, Councillor Horgan.
Thank you, Chair.
Just to sort it out. There'll be a series of member questions, 3 or 4 probably, and so if you could make a note of your answers, so we'll ask you to take them together rather than one by one. Sorry, Councillor Horgan, is your microphone working now?
I think so. Yes, blame the technology. Thank you for the paper that you submitted. Unfortunately, it paints a very honest picture, showing that the trajectory of rising demand for diagnosis and support is not a good one. And then to run parallel with that, we've got the 2026 Schools White Paper that proposes that EHCPs will be reviewed at the primary to secondary school stage and post-16 transition points, putting more strain on the very finite number of resources. I'm interested to understand how the ICB and clinicians will cater for that additional workload, because it seems to mean that there's going to be a lot more diagnosis required, not less, and already it's off the scale. And I'd be interested to hear a little bit more about the long-term plan you've got for addressing the waiting lists, and if there are any short-term measures that are in place. Thank you.
Thank you, Councillor Garvey. Can I suggest you ask both of your questions together, if that's okay? Again, the microphone, please.
What are the autism referral and diagnosis rate rates for girls and women in Cambridgeshire compared to boys?
Again, it's a little difficult to hear. If you can just position the microphone a bit closer to your mouth, that'd be great.
Shall I repeat it? Yeah. What are the autism referral and diagnostic rates for girls and women in Cambridgeshire compared to boys and men?
Councillor Dupre.
Thank you. My question was that the report says, while diagnosis can be valuable for self-understanding and longer-term planning, the priority for local services is ensuring that children and families can access appropriate support when needs are identified, rather than waiting for diagnostic assessment. So my question is, how do children and families demonstrate need if they don't have a diagnosis? Thank you.
And access the services, exactly. Councillor Fane.
Thank you, Chair. My question was related to the importance of early diagnosis and support in achieving the best outcomes. I was concerned to read, I think I read, although I can't now find it, that the average waiting time for an autism assessment is 17 months. And I'm wondering, in the light of that, whether it would be helpful to have some process of initial assessment, which could inform some early support with second stage for those requiring a more significant assessment.
And I'll just add before handing back to you, the waiting time for diagnosis has been a long-running problem. It's not just emerged this year, has it? And what we want to do is to have confidence that that the issue is being tackled. So what have you actually done in the last 12 months that has made a difference? And what is that difference? Over to the guest, please. You choose in what order you wish to speak.
Thank you, Chair. My name is John Pebbody. I'm the Service Director at CCS. So the first question around that issue of the new SEND reforms and the idea of EHCPs and how they'll be reviewed. If I'm honest, right now we don't know that. It's so soon that publication has come out. You're right to identify that it is going to put additional strain on us, on all of us. But actually, how we'll deal with that. Right now, I don't have an answer right at this moment. The report was published 2 weeks ago, so it is. You're right to flag it. It is something that we're talking about, but as in terms of solution, right now I can't give you anything to give you any confidence. I think the second point was about long-term versus short-term, which I think was also a point in some of the other questions around what have we done in terms of the short-term. Let me just pick that up for now, and that might lead into. So in very recent times, I mean, I would say that we accept that waiting times is unhelpful for families. We get that, and it's disappointing. You can see from the data, it's linked completely to demand. So what we've tried to do a couple of things. They're highlighted in the paper, aren't they? One is around trying to support families earlier and sooner. So I've literally this morning come from Ely, where there's a community appointments day taking place. So we wrote to all families who are on our waiting list, about 250 of them, with the CB6, CB7 postcode, and invited them to essentially a workshop to meet professionals to talk about what matters to them. So I left it in full flow as I came away. I think we'd had about 40 families turn up. About 80 said they would coming. So hopefully there'll be more coming this afternoon. So that's about trying to offer earlier support. In terms of the diagnosis element, I mean, it's an interesting question you raise, which is around the need for a diagnosis to get support. The Children and Families Act doesn't say that, does it? It says that actually support should come regardless of a diagnosis. It should be based on needs.
What I'd also say from very young children, so our very youngest children, so preschool children, come through early support. They don't wait these sorts of lengths of time. So children who come through early support, typically in terms of autism and are diagnosed well within sort of acceptable timelines, if you want, in terms of NICE and what have you. So often anything up to about 13 weeks, but which is, obviously is much speedier. So very young children, and they're often the children who have learning disabilities. So that or those children on that autism spectrum who have a learning disability are seen through early support much earlier. In terms of other children, our referrals come from schools, so they come from Senkos. So because we recognise they are best placed to recognise need, so they will assess need, and they'll obviously talk to families, and then decide whether that child would benefit or has those needs for a diagnosis. So would then make that referral. But we wouldn't expect that at that point for support to stop. Support would still continue whether they have a diagnosis or not. Interestingly, last week I was in a meeting looking at the SEND reforms, thinking about a way forward in a Cambridge school with the Director of Education and many partners, and we talked about a couple of children. Both of those children had a diagnosis of autism, but one, I remember because he was only 6 years old, had only attended school 3 days out since September, and he had a diagnosis. So it isn't only about the diagnosis, it's also about how we, and I'm going to say we because it's absolutely a system thing, support children better to have their needs met. I think I'm answering the questions in the order. The gender question in Cambridgeshire, so looking at looking at the children we see, it's typically 2/3 boys, 1/3 girls, and that I think is fairly consistent. Caroline, is that right for you?
I would say that is slightly different in the older age range. So we see about a 60-40 split. So Peterborough, more boys, and Cambridge, more girls. But that's 12 plus. So it tends to present maybe slightly differently in that age range. So I think we have very different presentations in the preschool group and throughout primary. And I was just going to elaborate on that to say where they come through. We have the CAMS neuro pathway. We are also quite often seeing young people presenting with a request for an ASD or an ADHD assessment that are also experiencing some core mental health challenges, and therefore the pathway works in it's not a diagnostic pathway. We are triaging the presenting need at the beginning, and if we will begin with trusted assessment and interventions for mental health challenges outside of a neurodiagnostic pathway. They don't wait for an autism assessment to access any other help, because we know that in teenagers they present with a wide range of challenges. I was just going to talk a little bit about when we're talking about the value of diagnosis, we have lots of conversations between us and with the system and with the ICB around a needs-led approach, and really putting the child at the centre and thinking what's going on for that person that's outside of a fixed pathway, so that we are trying to open up the possibilities of meaningful help as early as possible for those families. And I think John talking about the community clinics, we do workshops for parents. We are while people are waiting, there's lots of information available on the United website. All of our referrals come via United for CPFT, and that's really, there's lots of signposting, but also it's thinking about what we can do that makes that feel that people are getting meaningful access to advice, support, and things that help them while they're on that journey. Because whilst I think ADHD is slightly different, because quite often people are seeking medication and there's valid need for that. With autism, if we're moving towards a more neuro-inclusive range of services that we're providing, then an autism diagnosis shouldn't be the key to accessing anything. We should all, as a system, we really need to be working towards more neuro-inclusivity on the whole, to which will likely eventually shift the need for people to be dependent on a diagnosis to be able to get the help that they need.
just going to say one last thing again about what we've done in the last year. So Catherine mentioned it, and it's in the paper. But the additional funding we've had, which was very short term, we have to get it used by the end of March, has enabled us to see more children. So we have seen upwards of 200 children with a different kind of model. So it's clinically appropriate, it's NICE compliant, but it's not so dependent on the doctor. So it uses OTs, nurses, speech and language therapists, and that's been interesting, actually, taking what we call a skill mix model, if you like, to see children. So we know we can do it if we have a bit more capacity, and by that I mean in this occasion it's because we had some funding to do it. We can see more children. We're committed to getting waiting times down. We should be within 18 weeks. That's the kind of, if you like, the national target. And that's what we should aspire to. No question about it. We understand completely when we talk to families. Yes, they welcome the support like they will from this morning, I'm sure, from Ely, but many of those families still say, the diagnosis is important, because they tell us that they recognise that it opens things for it shouldn't do perhaps, but it opens opportunities and doors for them in terms of support. I think it just helps understanding as well, doesn't it, a diagnosis for families.
Thank you. And then in addition to what we've done, so it talks in the paper about the improvement plan. So we very much did a big piece of work to bring together a number of partners across the system to understand what the needs were, and that's where this needs led. And that was the sort of desire that came. How do we focus on the needs of the children and young people? And there's been additional projects. So the PINS project, which is partnership in neurodiversity in schools, just remembering the acronym, that again, I think what a lot of work we've done is actually highlighted. So we've been working at that very early intervention stage to think about how do you identify children who may have additional needs that's impacting on their education and their well-being and their sort of functioning. Our mental health support teams in schools, they are again inclusive of need of children and young people. So again, they work very closely with schools and will provide programs to support children and young people at a school level, that early intervention. That's positive, but what that has also done is it's highlighted a number of children with needs. Where I do think we are challenged, and that's a national challenge, is around specific funding that's been flowed through for diagnosis specifically. There's been lots of programs looking at early intervention, but the way that the NHS structure of funding often means that certain funding has to be for particular programs of work, and there hasn't been funding aligned particularly to the diagnostic element of autism and ADHD, which is where we see one of the challenges. So although we've done lots of work around that identification and early support, the area that we do acknowledge and we do is still an area is about that. How do you do the diagnosis? And the workforce is a big challenge. John's just mentioned the model, and that's what we're starting to look at. Is there different ways of doing it? Because if we rely on our existing model of community paediatricians, they're a really small workforce nationally. There's very little growth in that. And if we don't start looking at ways of delivering that differently, then we are going to become more challenged. I don't know if Pam wants to mention a little bit more about some of the sort of future around the ICB thinking.
Yes, so as we form as Central East ICB from the 1st of April, this area of neurodiversity, mental health in children, the unmet need is absolutely one of our strategic priorities. So whilst we're not different to other areas with this challenge, there has been a national task force that was set up to look at ADHD identification particularly. So often we confound those two things together. So the neurodiversity pathway has been the only route previously for our children to get support and assessment. Actually, there is a need for us to have a very clear ADHD pathway and enable colleagues here presenting to you today to be able to do the good work that they're doing. That task force said it's down to local determination of how you construct these things. We have the benefit of having 3 different areas that have been working on this challenge. So as was mentioned by Catherine, we can bring best practice together across that patch. So it is a priority. And when you see our strategy known as Our Way, you will see it front and centre to that. So we'll continue to work with clinicians and stakeholders to make sure that we get a service that is appropriate for that part of our population and support the families. I think what's really interesting that you've heard today is that a symptom-based approach is appropriate, because actually if you don't meet the threshold for diagnosis and you still have a challenge, whether that be a parental challenge or whether that be from an individual, we still must offer support. So, you know, getting that shift, as my colleagues have talked about, to a different way of looking at this challenge is really, really important. And I think that's something that we can do with colleagues around the table, because it does transcend into all of our spheres of work, whether that be Get Britain Working, whether that be you know, housing and employment growth, all those sorts of things. Actually being a more neurodiverse community is actually really, really important. So what we don't want to do is medicalise individuals that can actually seek support elsewhere through meaningful work and employment, all of those sorts of things. But it does require a mindset shift. And that isn't just from a medicalised approach.
I suspect that Councillor Dupre will want to come back, I think, specifically on the point made by Mr. Peabody about a needs-led approach. The concern that we expressed was about, okay, you can get your needs met without necessarily having a diagnosis, but how do you know what services are there? How do you access those services? That's our concern. But I'll ask Councillor Dupre to come back to add to that.
There is that, and I'd be interested in the answer to that question, but I may be alone in this, but whenever I've had approaches and interactions from parents of children who are experiencing difficulties, even if they have a diagnosis, it's often very difficult and they find themselves fighting for the support that their children need. How much more so if they don't have a diagnosis and if everybody's in the dark, the parents as much as anybody, where resources are in short supply, where demand far outstrips what's available. How do parents get their foot in the door to accessing those services? The Act may say that they can, but the reality may be saying something very different.
Councillor Malinowski.
Thank you, Chair. I just wanted to come in as well on something that arose from the discussion just there, talking about sort of signposting for other services and other needs that come up, because the conversation reminds me of sort of the experience of myself as somebody who is transgender. And obviously we do have gender non-conforming youth and people dealing with gender incongruence, and this often has an overlap with autism and ADHD. And I just wanted to ask if, you know, servers, if that increase in demand is also there in that, and that's something that you pick up at that stage when those, you know, troubled teenagers potentially are coming forward with those issues.
And I remember Councillor Horgan, in the preparations, you talked about the relationship between more diagnoses and whether service capacity was there. Would you like to put that question?
Well, it wasn't actually a question, it was a statement of fact. My daughter, my youngest daughter, is head of a special needs division in a mainstream school. And we had a conversation 2 weeks ago. Her intake for her division next school year is 4 students. She's been told she's got to take 17. That's the reality. That's the reality. And it was very difficult as a parent to actually support my daughter through that very difficult discussion that, you know, sometimes life isn't fair. Not a question, it's just an observation. And so if you have anything you can give me to tell my daughter to give her some hope, please do.
And I think just extending that, so the question's put, say the short term works and you get more diagnoses, is there not then a bottleneck on the services? Are you planning for the services to expand in the way that we hope the diagnosis will expand? And if not, will we just end up with more diagnosis but less need being met?
Okay, interesting questions. Forgive me for just so this is not just a medical problem in terms of meeting need. Okay, it isn't just the responsibility of the NHS to meet need. It is a responsibility of I guess the Children's Strategic Partnership, so all partners, so whether it be the county council, whether it be the voluntary and community sector, it isn't just the NHS. So typically schools are well placed, aren't they, in terms of to try and support meeting needs. What you described there, we absolutely hear that schools are under tremendous pressure to take more children with additional needs. It is a real challenge, but it isn't just the challenge for the NHS. If Sarah Callahan was here, I'm sure, the Director of Education, I'm sure she would say similar things. This challenge is anchored in Inclusion for All, the SEND strategy for Cambridgeshire. It's one of the work streams to try and tackle waiting times and support people while they're waiting. But that's about inclusion. So that's about all of us supporting children and young people who are neurodiverse to be, to get the best out of their lives that they possibly can and be, the adults they want to be. In terms of your question around how you know what's there, again, it's again when we had our Ofsted CQC inspection, the SEND inspection, which I'm sure you know about a year ago, that was one of the things that the inspectors fed back to us. Is there's lots of great things happening in Cambridgeshire, lots of really good things, but actually families were saying, but where are they? How do you access them? So there is work going on through the Inclusion for All strategy looking at that to try and make sure that we do have, and we can talk about digital offers, we can talk about websites, can't we? We can talk about, like this morning, the community appointments day, all those sorts of things are opportunities, we would say, to try and support families. We work closely with Pinpoint as well. So again, you may know the Pinpoint conference a couple of weeks ago. Martin Perbrick was there as a DCS to talk to families about what's important for those. A lot of parents, members of Pinpoint are in this group, are parents whose children are neurodiverse, who are unhappy sometimes around the lack of support that comes from the system. So you're right to say it's a common theme. Again, the inspectors heard it, that it's a fight. It's a fight to get an EHCP. Again, I know you'll be probably aware of that. It's a fight to get a diagnosis. We need to try collectively to make it easier for families so they don't have to fight. Hopefully the SEND reforms will assist us with that. So it will make it less confrontational, less of a battle, we hope. But right now we need your help, because the narrative out there for families is you need to fight, you need to complain, you need to fight the system to get your needs met. We don't want that. None of us want that. We want families to be able to get the help when they need it. But I think it is a collective ask. Your question, I'm not so sure about. Maybe Caroline, do you want to come in?
I can come in on that, and thank you for raising it. I think it is certainly something we see more of. I don't have data, and we're not talking huge numbers, but we do absolutely recognise the link between neurodiversity and gender incongruence, gender questioning. We are working, there will be the regional gender service that will be led by Adam Brooks, and we as CPFT are working very closely in partnership as the local mental health service provider to think about that whole pathway through CAMS and through to specialist gender services. It's very early days, that service hasn't launched yet. I would be very happy to have a conversation with you outside of this forum if you'd like to do that. We do engage with the Kite Trust. Our staff do actively seek they want to be informed, they want to be knowledgeable, they want to get it right, and it's very encouraging in our workforce, that they want to be able to connect with these young people, recognising the importance of those interactions and how to do that in a supportive way and to feel confident in doing that. So we've got lots of things that are going on around that, and certainly is very much part of our commitment to being needs led and inclusive, and working with the person that's presenting in front of us in the way that's most meaningfully helpful to them.
And I just wanted to pick up the question about the bottleneck. So I think as it's been mentioned, so I think there's a slightly difference between autism and ADHD. So if you go down the ADHD and then you need a medication, we need to make sure in the work that's happening around the review and the redesign of those pathways that we have capacity for the assessment and diagnosis element, but also for the treatment and the ongoing management of children who have to who for which that medication is helpful. I think for autism, the diagnosis, there isn't then a treatment pathway as such. It's about, sometimes for some people, it's about self-identification, understanding yourself, helping people understand you better, and therefore how do you get the support you need. But that support is there within, as John has mentioned, in the community, in different groups, in schools. That support for autism should be there. So I think the bottlenecks are slightly different, and the way we need to construct the pathways will be different for those two groups. But we also need to be mindful there are children who may well have a dual diagnosis of both those areas. So I think it's how we approach reviewing those pathways to stop those bottlenecks, because as I say, we're very aware of the two different approaches.
Okay. Apologies to members, I jumped ahead in my reference to the notes, so some members haven't had a chance to ask the question yet, even though it appeared earlier in our preparatory meeting. I'll have one more round with pre-prepared questions, so when you get your chance to speak, any of the questions that you've prepared that you wish to ask, you're welcome to. And I've seen Councillor Kane, but I'm going to bring Councillor Fane first. With his questions. Councillor Kane.
Thank you. I mean, I think when we look at the fact that we've got 1,137 children waiting over a year for a diagnosis, that's quite shocking in itself. But then to read in the report that this might not fully reflect the actual demand because of right to choose, I really wanted to understand how the ICB is monitoring the impact of right to choose on assessment of local demand. And I've been approached by residents who are saying that they've taken the children through a right to choose route, and then subsequently on getting a diagnosis have then had problems then when they go to their GPs not recognising this right to choose route, although it was through agreed practitioners. And I just really wanted sort of some commentary on that, please.
Thank you. Councillor Horgan.
I just wanted to build on, I think the workshop that you spoke of today in CB6 and CB7, and I'd be interested to understand any other. My question was around about thinking outside of the box, and I would sort of put that workshop in the thinking outside of the box type category. So I'd be interested to hear what other sort of different ways of reaching out to people that you've been able to employ.
Can I check if Councillor Dupre wanted to come in again?
Yes, please. The question I wanted to ask was about the local and national autism strategies. And both of those, as I understand it, are due to expire during 2026. So I wanted to know what was happening to update both the national strategy and the local strategy in the light of increasing demand and changing circumstances. Thank you.
Thank you. Councillor Garvey, please.
Yes, it's when with school-aged children, it's important the help that they get in schools for behaviour management and so on. Does the NHS or yourselves collect data about what is really good best practice in schools, or how schools are managing with the with these children?
And thanks. And for me, adding on to the question from Councillor Dupre about strategy, I remember sitting in this room in 2021, 22, and being told that the new autism strategy was going to solve all the problems. And there were huge waiting lists then. Girls were underdiagnosed then. There was a lot of patient dissatisfaction then. And we were really told that the new strategy was joint between the health service and local authority. They'd worked on it beautifully and it was going to solve all the problems. And here we are 5 years later. And frankly, we're hearing that in terms of satisfaction, not much has changed. And that's obviously disappointing. I don't accuse anyone involved of bad faith, and I know the challenges are high. And by the way, to Pam, I acknowledge the huge pressures and challenges there are for the ICB at the minute. We do understand that and certainly take account of it and express our goodwill to you and your colleagues in relation to that. Nevertheless, it is disappointing that so little has apparently changed in 5 years, despite the expectations of the new strategy. And so alongside Councillor Dupray's question of what's going to happen in terms of it supposedly ending this year, what can you say about what failed in that strategy? Is there a recognition of what hasn't worked in it? And if there is a recognition of that, it probably gives us more confidence that the new strategy, if and when it comes, can be more effective. Thank you.
Thank you. So I'll pick up the point around the right to choose and the point in the report about the diagnostic. So more people are going out to right to choose, and it's a developing area, I think, for us as an ICB and nationally. What we've done, the first step we've done as an ICB is to look at how we can quality assure providers. So this is something that's been happening over the last sort of year, 18 months nationally. We've started with adult ADHD providers, and that's basically to ensure that we can, because what we're asked, GPs are often coming to us saying, well, who do we recommend as a provider for our families? So we have looked at from an adult framework, and we're now looking at for children to make sure that the providers are on a quality assurance framework. So making sure that they are delivering nice concordant interventions, that they are quality assured, that we feel that we feel that we can say to families, yes, you can go there and they've got a quality to their delivery. That's a piece of work that we're starting. That's obviously it's progressing, but with all the change in the ICB, that just needs to go through the process. In terms of how we're actually being able to understand that, again, one of the things we've been working with our finance colleagues, because at the moment the process is an invoicing process, to actually understand these invoices, what are they for? Is it children? Is it adults? Is it autism? Is it ADHD? To get a sense of that. So that's a piece of work that we've started this financial year. Some providers have been more forthcoming in providing that information, so it's a bit of a work in progress, but it's about us understanding and having the data and information to understand who in our population is seeking. We've also been doing work. We went to the primary care. They have sort of workshops. We went a few weeks ago to talk to them about that, putting information out there on the ICB website. United website's got a lot of information out there as well to help families understand, if you're going to look, because we don't have a preferred list, what sort of things do you need to consider, and things they need to think about, practical things like if you're going to somebody who's delivering in Devon, which I have heard stories of, then you need to be able to have the means to get yourself there for follow-ups. And also there is work with primary care. So primary care are allowed to do, particularly for our ADHD children, deliver shared care arrangements. So that's where they work with the provider who's done the assessment to titrate and monitor and deliver and prescribe the required medication. Again, that's something that GPs, because the GP is the one professional who can refer to right to choose. It's not something you can access through school. The GP needs to have that conversation. So again, a lot of our work is upskilling the GPs as well in that, to make them understand their responsibility to their patients, to understand if a patient comes to them, it's not a tick box, actually, it's a conversation. What are the needs here? Have you engaged school? Because like we've already said, these children do not just need a medical pathway, they also have a huge amount of social and educational need that need to be factored in. So how do we make sure that it's not just a label, it's that whole package that people are going for?
the question around the CB6, CB7 community appointments day today, I mean, I probably should have said earlier on, actually, the work that's underpinned by the new neighbourhood model. So again, you'll know that the guidance was published, wasn't it, last week? And so we've been working closely with all the neighbourhood teams, and we're kind of, we're using the term pilot, but we're trying it first in CB6, CB7. And then we'll evaluate that and see how it's gone, and then look to roll it out. Certainly, South Cambs, Cambridge City, that everyone's keen to do it. So we will definitely, I'm sure we'll roll it out. I think we'll adapt it slightly because we've learned even this morning a few things immediately, you know, some very practical things about what we need to get right next time. But the plan is to roll those sessions out. What will be really interesting, again, it's only happening today, is to hear what those parents say. And that whole bit around what matters to me is a different way of couching things. So these are children who are waiting on a waiting list, but the conversations that people are having with these families is, well, you know, what matters to you? Now, it may well be that families say a diagnosis, but early indications from with that team is families don't say that. They talk about their mental health difficulties. They talk about their social difficulties. They talk about their problems with their neighbours. They talk about poverty. It's not, do you know what I mean? It's a much more holistic kind of model that we're looking to try and roll out in terms of the community appointments day. So there this morning, there were a paediatrician, there was a speech language therapist, but Ely, the council was there. The voluntary sector was there. There was a person doing health checks there for adults. It was a much more holistic view of health rather than just a focus on autism or ADHD. So yeah, we're ambitious to try and roll them out, you know, once or twice in each locality, probably in each neighbourhood over the next year or so.
Yeah, I suppose I would just add to that. I think John and I were talking on the way in here, and there are opportunities as well for us to join up together and do that together, so that we can make sure that we're maximising on the reach and the people that are able to access those things that would be additional help. I just wanted to, if it's okay, I think if we go to the question about do we collect data on schools and how they're managing, and then I think there were two questions about National Autism Strategy and the update, and the previous one that probably sit together. In terms of collecting data on how schools are managing, we don't collect, the NHS doesn't collect data on schools. So I wanted to empathise with the councillor and your daughter, and you know, I think we talk to schools, we talk to education providers. I know that CCS do lots of work with the Senkos, and you know, to really and pinpoint to make sure that we are hearing the challenges and understanding the challenges, and that we are having conversations as a system as to what we can do to make that better. I think there's work to be done there, and we've talked a lot today about about it being a system issue, and actually where we currently are in this world of a diagnosis being seen as a door to open access to help. Actually, after we've done the diagnosis, there isn't much else that we can offer. I think for the primary age range, it's a different process. Certainly for CAMS, we would still continue to work with a young person to think about what that might mean for them, because they tend to be taking a bit more, you know, it's a bit more self-managed, and it's more about self-understanding in that sort of 12 plus age range. Did you want to add anything to that, John? Because I think it's more you've done more of the work with the Senkos.
Yeah, I mean, again, this will feed into the local strategy question as well. I think, you know, that there is work going on with schools. So Catherine mentioned PINS, so that's a project to support schools to be able to not manage individual pupils, but actually to manage a neurodiverse classroom. And it's about providing teachers and Senkos and teaching assistants with the necessary skills to be able to do that. And you know, it's a national programme, and it evaluates really positively. Schools like it, they do, and see it very positively. The early concerns work we're talking about, that is again with two local primary schools and a secondary school in an area, trying to support that school. And again, it's a model of thinking, well, actually, if it kind of works here, can we roll that out? Can we do it across many other schools? So there's lots going on. The bit around strategy, I'll maybe let Catherine come in, but all I would say is it's quite a strong word to say it's a failure, because that in terms of progress, I think where we have made progress, waiting times, no, I get that, but in terms of support, I think there is a lot more available now than there was in 2021. Definitely, there's a lot more of what, there's, we've worked closely and helped fund, information for parents whose children are neurodiverse. Definitely, there's a lot more there. I think parents do say it's hard to find sometimes, and they're not quite sure which way to turn. But I think we have made some progress. I take your point that we still have children waiting far too long.
And I think in that intervening period, of course, we had the COVID pandemic, which affected our young people so significantly. And there is national debate and inquiry as to the connection between COVID and the presentation of our young people now. We don't have those answers, but it does line up with that period of the strategy, which is unfortunate for the strategy and more unfortunate for the children, because we have seen such high levels of demand post-COVID. We will await that inquiry into the hypothesis around how that has affected the presentation. But I think it is worth being mindful that those two periods cross over.
I'm not sure I heard it, and if I missed it, I'm really sorry. But did you say whether in response to Councillor Dupre's question, there will be a new strategy or it'll be rolled forward? Did you answer that? And if I missed it, I do apologise.
There is go on, do you want to do it? Yeah. All I was going to say, there is a national review going on. Peter Fong is leading that review, and is asked, and certainly we're being asked, as other providers are, to give examples of best practice and best models. I'm not sure of the timeline.
No, I was just going to say, so in terms of what next for the national strategy, say there is work. So we, as Pam alluded to earlier, there is the task force around ADHD, and then there's a review looking into autism, but quite what the anticipated outcome and timelines, I don't know if we've got that at the moment. And I would say, just sort of to round up around the local strategy. So I think we've had some challenges around change of personnel and the running of the strategy. So I do think that was something that impacted, but there's been an awful lot of work on the ground. Another big area that the strategy did also work towards was the development of let young people learn to speak autism as key workers, and we've really significantly reduced the number of our young people who are in inpatient mental health beds. So there's been lots of work across, but I think you're right in your observation. What the work hasn't impacted on is the waiting lists, and that is a multifaceted thing that nationally people have been rolling out this strategy across the country. It was a national strategy with local implementation, and I think the demand has just become a real challenge that nationally we're all struggling around. How do you do that despite lots of positive work? But is it around the identification and actually the excuse me, the awareness raising? People are now feel more able to speak up when they're not feeling, they're questioning themselves, they're not sure how they're fitting in, they're identifying their needs and they're seeking help, which is really positive. And that's one of the things that we're sort of seeing in services. So yeah, I wouldn't say it's a failure, but it's not addressed the waiting times in the way that we would have anticipated and would have hoped.
I think we're nearly there, but I will ask Jess from Healthwatch if she doesn't have to, but if you want to say a few words.
Yeah, so I'm glad I come in at the end, actually, because I think I can support in some way. So we hear from lots of people about waiting times, obviously. We're not arguing against that. But there are other concerns. So the partnership boards, we have a learning disability partnership board that we run with the councils, both councils. And a lot of this is around primary care settings, but we are seeing it in the acute trusts now as well, around people's lack of understanding and making reasonable adjustments around their conditions. And quite often, some of these people have complex needs as well. So there's a lot of physical disability in addition to autism or ADHD support needed, and it can overshadow their care needs to the point where some of their other health needs are overlooked. So from our point of view, I mean, we've been running our Youth Watch, actually we're doing a neurodivergent project at the moment. And we run a primary care workshop just recently, and we did it in good hours so GPs can attend. We had 2, which was disappointing. However, they got a lot from that because they were with young people with autism, and they wanted them to tell them what they needed to do. And a lot of it is around about giving more time in appointments, communicating needs, and the sounds that, making it reasonable adjustments so it's a safer space for people to bring their other health needs going forward. So I think I'm really looking forward, and I'm really pleased to see the ambition around a more joined up single pathway around the integrated neighbourhoods, and how that's going to affect diagnosis, but services going forward. But also the need to have some awareness training in primary care. I think it needs to be included in that, not just around diagnosis, but we can't expect everyone to be specialists, but that awareness and making sure people are able to open up in a safe space through a single door is what we've been hearing and coming through to us. So I'm hoping that I could support you with some of that through Health Watch, and we can connect you with those when you're co-designing those services. I can connect you with those people to help you make a better pathway.
Okay, we are at time, so just 30 seconds, please, Councillor Dr. Nawaz.
Thank you. To be clear, autism is not an illness. It's, just being different. They could be having a higher IQ than average, in fact, and that's the concern for the diagnosis is accentuated by the fact that you may have to wait 2 years, 3 years. A lot could happen during that period, and I worry about that. To repeat the chair's comment that not to accuse anyone of bad faith, but there is a concern that 5 years down the line, we are still talking about, quote unquote, the need to have pathways, the need to develop capacity. I would have thought that this within those 5 years, this would have been done. And I'm sure there are good reasons why it hasn't been done. What steps have been taken to ensure that these waiting lists can be reduced? Have any steps been taken? Any red flags raised?
Okay,
and also, Get Britain Working is a very important project. How have you tapped into that? Because that can bypass many pathways. Thank you, Chair. My apologies.
No, I understand the interest, but we are at time. Some of that I think you've covered already, but I think it's good if you get the final word as well. So can I have just a 1-minute answer to Councillor Dr. Nawaz, please?
I'd have to link into the getting people to work element. I think the waiting times is a challenge. There has been a lot of work, and I think it's probably not a fair representation actually of that comment in the paper to say that things haven't moved forward. There's been lots of work. I think there is just a national challenge around workforce, about demand, about the complexity. We haven't really touched on that, but I think one of the real key things is our children are coming through to services and their complexity of need is increasing, and that's not about necessarily their complexity of their health need. It's about the complexity of situations and circumstance in which young people are finding themselves, and that's meaning that it is taking longer to gather the information because these are lifelong diagnoses and they need to be made correctly and they need to be given in the best evidence-based way. And therefore, for children, young people and their families, it's really right that we do it in the right way and that we deliver things and we make sure that we do it in a really robust, high quality way.
Very much. Although you probably think you've heard a lot of negative things from members, all of our recommendations try to be balanced and they try to be constructive, and also to encourage and praise where possible. I do a summing up, which I'm about to do, and then that's compared with the notes from our committee secretariat to form the final recommendations. Certainly what I've heard is that there is a continuing deep worry about waiting times that we must not not minimise. There have been short-term efforts to try and address that, and we want to welcome those. But I think we want to indicate that we still feel that there's a long-term challenge there when it's not met. I think we'd want to recognise that there needs to be increased funding towards diagnosis to build capacity. We've heard and welcome the fact that this area is a strategic priority for the ICB. We've heard that there are particular pressures post-COVID and in the complexity of cases. So we want to acknowledge that, but it being a strategic policy, a priority rather, we do want to see results from that. We've heard examples, including the workshop in Ely, the workshops with GPs, the connection to the neighbourhood model, the single pathway, where local health partners are seeking innovation in tackling this issue. And I think we want to welcome and encourage further efforts along those lines. We recognise there was a historic problem, not just in Cambridgeshire, but nationally, about diagnosis for girls. I think we welcome the information shared today, but would want continued attention to make sure that girls are not underrepresented in terms of diagnosis. We'd want to express support for the needs-led approach. We're not absolutely against that at all, but we've expressed concern about whether and how you access services if you don't have a diagnosis and don't have awareness of what those services might be and some information to get you through the door. I think we welcome the fact there's an improvement plan, but over time, we haven't seen the improvements that we could reasonably expect. I think we should acknowledge efforts to not medicalise young people if they don't need to be. The holistic approaches Mr. Peabody was talking about, the importance of employment, which at the end Councillor Dr. Nawaz was talking about. And we would acknowledge that partners have a role to play in this, as the guests have all indicated. On strategy, I think we should note that the current strategy is supposed to expire next year. There seems to be a bit of a black hole about what happens next, but there is a national review. We've been informed. I think we would welcome the fact that local actors are contributing to that national review, but how its results are then fed back into the system here, I think we haven't heard, and we would want to see. We've heard that we want to encourage dialogue and feedback from schools. It's not the health service role to have all the information from schools, but to the partnership with them is important, as I think guests have acknowledged. And we've heard that you recognise in particular the importance of services in relation to primary age school children, which I think we would welcome. And we heard at the end there the suggestion that primary care needed awareness training, and the offer from Healthwatch to be a partner to assist and to support that. Are there any particular conclusions, members, that I've not said there that you would want recorded? I don't see anyone adding. Are you happy with all of that, Rashenda?
Yeah, thank you, Chair.
Okay, in which case, it's a big room, this, and a bit echoey, and it's been quite a sober discussion, but I hope you feel that we've been genuinely interested in what you're doing, obviously wanting to challenge it, but I'm sure you're used to that. But we've also very much respected the roles that you play and the answer that you've given. So to our guests, thank you very, very much for appearing. And can I ask the next guest immediately to join us at the table, because we're running slightly behind. We did deal with one issue in advance, so we're not too badly behind, but I do want to make sure each item gets properly looked at. Thank you very much. I hope you enjoyed listening to at least the latter part of that, and gives you an idea of how we operate. We're going to look item 5 at primary care in Cambridgeshire, challenges and opportunities. The written information is on pages 29 to 44 of your agenda pack. Pam Green, Integrated Care Board's Director of Neighbourhood Health, Place and Partnership, is staying with us for this session. You're a sucker for punishment, if I'm allowed to use that joke. Dr. James Booth, it was a joke, by the way, we're not here to punish you, right? Pam is joined by Dr. James Booth, Medical Director of the Local Medical Committee for Cambridgeshire and Peterborough, Dr. Nazia Ullah, a Fendland GP and a member of the North Care Partnership Board, and John Rook, the Management Lead for the North Place Partnership, who's a much valued partner and collaborator with us. So it's great to see you back here, John. Once again, I will begin by asking Pam to briefly introduce the report. I do ask it to be brief to enable us to have the maximum time for questions and dialogue.
Thank you very much, Mr. Chairman. And I will keep it brief because the paper's extensive, so I don't think we can do it justice in a summary anyway. So we'll take that through 3 questions. What's really important to recognise is that the paradigm shift that the neighbourhood and place agenda will bring to our population within Cambridge and Peterborough. And whilst this is a new political document and the most recent guidance was released last week, as well as the contract archetypes which they're being referred to, so the way that we will commission services going forward, was finally released and for consultation last week. This is not a new concept. So many of us have been working alongside our primary care colleagues to wrap services close to the population. But this is very much about now scaling that across all of our population, seeing that as a recognised offer and a way for us all to work together as a multi-agency approach for our population. As has been referenced several times today, our data crosses over. We interface with the same population, and it is incumbent through the neighbourhood guidance for us to do that in a much more coordinated way, so that we can make the system much easier to navigate and that we can improve the outcomes for the population. As an ICB, as I say, we will be forming on the 1st of April officially in our new stance, and we have absolutely preserved the local governance around neighbourhood working to be able to support our care partnerships of north and south of our geographical area, and the general practice offer that sits within that. So I will finish there and I will take questions, but Dr. Nazim, we will absolutely address work well within that, within this item, because it has been an exemplar work to show how neighbourhood health will work going forward, and that app connects directly into Get Britain Working. So we will cover that now. So over to questions, I think.
Yeah, just on that last point, we'll make sure it's minuted because it obviously covers both of the priorities that we're discussing today. And now Healthwatch last year got patient feedback in this area, so I think it's appropriate next to ask Jess to comment.
I haven't got any direct questions. You've probably seen the report. There's quite a lot in there, so I'm going to leave this to councillors.
Okay, feel free to come back later if you hear something that you want to comment on. I'm going to jump directly to Dr. Ullah because it's really important to have a GP talking to us, and obviously you'll be contributing throughout. But I just want to ask you for some initial observations of what can do better for primary care from your position in a particular practice, and I'd welcome your presence here.
I work in Fenland in a small practice. I am a jobbing GP.
Just to say, the way that you get heard is you pick it up and you move it closer to you like that. Sorry, but it is quite a
normally don't have a problem with this. I'm loud enough. General practice, in terms of this report, we
generally welcome the direction that this is taking. We want care closer to home. We want to do prevention rather than cure, illness. And we think that embracing technology is the right way to go. But we are really worried about the fact that everything seems to be pushed in the direction of general practice or primary care, without this being adequately resourced, without us having the infrastructure to take this on, because it's not beyond our capacity and it is the right place for most of this to sit. And, I'm old enough now to have done this a few times, and there's been quite a few plans along the way that we've seen. This one feels like it could be different as long as we are correctly resourced to be able to do it. And the new pressures that we're putting, and I mean, I've seen Jess's report about the feedback that we've got in general practice, and we take that. We are pressed. It is hard to get a GP appointment, but it is a lot less hard than it was a few years ago because of the changes that we've made. And there is a lot of appetite in general practice at the moment to lead these changes. So generally hopeful, but worried about the impact of this on our day-to-day.
Thank you very much for those opening remarks, and thank you again for being here. We're going to divide up the questions around 4 lines of inquiry: trends in primary care provision in Cambridgeshire, specific challenges and opportunities, the impact of the NHS 10-year plan, and annual. And there's if we have time, a question about the annual health checks for people with learning disabilities that we dealt with at a previous meeting. So let's do questions around trends in primary care provision in the county, and I'm going to ask Councillor Dr. Nawaz to be the first questioner, please.
Thank you, Chair. You're absolutely right, Pam. It is a huge shift. It's a paradigm shift in primary care. And I think the doctor is also spot on that so much has been shoved down the line onto the GPs. And that kind of contextualizes my question that are we really ready for this paradigm shift? If you look at the ratio of GPs to the number of patients, and I think I will do a follow-up after we have been given this figure, Chair. Thank you.
And do you mind asking the question that's at the bottom of the sheet, but under this heading at the same time, about housing developments?
Population growth? Yeah, okay. Now, this kind of follows on from my previous question to do with the GP and patient ratios. It's an extension of that. We're building so many housing developments. There is such an increase in population, and the facilities are proving to be inadequate. I hear what you say about the improvement in getting appointments and so on. That's a good positive development. However, the observational view is that it is still not adequate. There is quite some way to go in that. What I would like to know is that what role does the NHS play in the process of procuring Section 106 monies? What is the process and what is the mechanism and the formula for calculating these amounts? Do you feel that it is adequately commensurate with the extra needs imposed on the NHS? And finally, are you a statutory consultee in the planning applications for these larger housing developments? Thank you, Chair.
Thanks. And we don't expect you to be planning experts. That was quite a technical question, but how much input you have is there. Do you mind if I just take 2 or 3 more members? Otherwise, the danger is we'll run out of time. Thank you to Councillor Dr. Nawaz. Councillor Dupre.
Thank you. Just under 3 years ago, we were seated in this room and we were, or the committee, I was a presenter then of my own experience, not a member of the committee at that time, talking about primary care access. And this followed on the back of the threatened closure of the GP practice in my own village, which was reversed. And we were looking at how that had been handled, and we were talking about vulnerable practices in Cambridgeshire. And at that time, the committee was told that of the 88 or so GP practices in Cambridgeshire, 13 were rated red in terms of vulnerability on a RAG rating. Around 15 were rated green, with the rest being rated amber. And I wondered whether you could tell us what the current figures are for RAG rating of vulnerability in terms of GP practices. Thank you.
And some questions from me at this stage. Firstly, the points in the report about difficulties of recruitment of GPs, turnover of GPs being challenging, we obviously recognise, but there are no facts and figures in the report. So it's very difficult for us to know how bad that challenge is or how challenging it is compared with other areas. You may not be able to give us a full set of figures here today, but could you comment on that and perhaps commit to sharing those figures with us afterwards? And then in terms of funding, already referred to more than once, I've sat in many meetings in this room hearing other GPs, not you, Dr. Illa, but other GPs say that at the moment it's 80-20, 82% to acutes, 20% to primary care, when it should be 20% to acutes and 80% to primary care, which I know is a simplified and perhaps oversimplified way of looking at it. But I think the challenge of actually not just talking about primary care being improved, but resourcing it to be so. Have you actually taken any decisions to shift money, or are the percentages just the same as they always were? And what are your plans to shift money towards primary care in the future, with some actually figures attached to them? Thank you.
Are we ready to go? Yeah, okay. So I'll address a couple of those points. I will go in order, but I think some of them will cross over, Mr. Chairman, if that's okay. So I just want to really come and as directors of primary care, you do become a planning specialist. That actually is part of the role. So I'm very happy to talk about 106, but we will do that in the context of neighbourhood design now. Acknowledging that this report does not have reams of data in it. I will be addressing that. We will bring you greater transparency on data. And there has been the development of a national GP performance database. So out of the GP systems now takes data, and that is available. There are obviously some challenges within the data quality of that we have to bring to you and explain to you, but we will absolutely do that for the future. There are also workforce databases that we can bring to you, but what we don't do so much now is talk about the per head of population relative to the GP numbers because of the change in the workforce makeup, because of the additional roles reimbursement scheme that came online just over 5 years ago, actually, and our GP colleagues can talk to you about that in more depth. The makeup of the team within general practice is very, very significantly different. So from occupational therapists to physiotherapists like myself, first contact practitioners, pharmacists, different work nursing skills, all now wrapped into the GP practice. And quite often through the triaging process, actually the caseload will be distributed directly to them, as opposed to going via a GP and then to one of the team, which of course used to be on a referral based approach, the way that it was done. So that shift has certainly happened, and we can talk about the financial benefits and workload challenges that come along with that. We will, I think, John, it would be appropriate to bring you in when we talk about national exemplars, because we have been involved in the neighbourhood health plan development. So there's 42 sites across the country, informing how wrapping around general practice in a neighbourhood approach would and what that would really look like for the future. So I'll go to John and Nazir in a moment around what that's been like to participate in that. From that, we will take significant learning around how we will support general practice for the future. And where I have delivered this elsewhere, actually what we see is that if we get that model right, the role of the GP is not about seeing all of that demand just in a different way. It's about bringing all the teams together and supporting the GPs to be able to do their job. Now, that is an alignment, and colleagues around your scrutiny table, particularly looking at Sally, are working with us, as well as Patrick, on how we align our resources to neighbourhoods. And that is the fundamental shift that we need to see in the delivery of all of our services. So looking not only at multidisciplinary, which would suggest that was within health and social care, but multi-agency. So all of our resources through statutory and voluntary sector services coming together and linking into those neighbourhoods. So it is a very, very different model to what we're seeing now. But we've had the ability to trial 3 sites within the national programme. And if I turn to John now to be able to give you some examples of how that has linked directly into primary care.
Thank you very much. I'm John Rook, Managing Director, North Cambridgeshire and Peterborough Care Partnership. We have 46 GP practices in our area. We have 13 integrated neighbourhoods that form our patch. And as Pam said, we've been part of the National Neighbourhood Pioneer Programme during this last financial year. And what we focused that on is an area of weakness for us, an area of weakness raised by residents, which is telling the story of an individual, particularly a vulnerable individual, numerous times. So what we've been experimenting with in that particular area is bringing together the best we have of social services, community services, general practice, voluntary sector, to support people, particularly frail people, with telling their story once and getting to the right agency for support. So that's what we've been practicing, that's what we've been piloting, that's what we've been testing. Of course, we've come across all kinds of information governance issues, as you would imagine, but that's the sort of thing we recognise is important to residents, but is also important to how we manage care. So that's one of the very practical examples of how we can and will do this better. I think just turning to the point that Nazia made, and I think you alluded to, Chair, was around how are we funding all of this? How is the shift of funding going to enable this? And that's an absolutely excellent question, because to have all this community infrastructure to support the shift of care that the NHS 10-year plan talks about, we've got to address some fundamental issues, like we've lost 26% of our community nurses in this country since 2010. So the 10-year plan is about building back that capacity bit by bit. So how do we build back community nursing? How do we build back general practice? How do we build social services? How do we build this infrastructure around people so that they have access to that in their neighbourhoods and more equal access? And that's really what it's about. So how is the funding shifting? Well, from April this year, hospitals are expected to get flat cash, so no uplift. That money over the next few years is supposed to be then reinvested into neighbourhood-based care, locally based care, primary community social services over that time. That's the purpose of the 10-year plan's timeline, is to arrest some of that predominant overinvestment, if you agree with the 10-year plan, in acute-based care rather than preventative public health interventions and locally based community general practice-based support for people. So that's what's starting from April. Of course, it will take the next 9 years of the 10-year plan probably to see that reversed. But there are some crucial things. So we spend more in this country on outpatient follow-ups than we do on the entirety of general practice. If you ask the public to vote on which one they put more value in, I think we'd probably get a good answer. So we've got to think about how we redress some of the balance of getting greater value for the public out of the investment we make, and where's that best done? And that's usually in the neighbourhoods. Could I give one more practical example and then I'll shut up? I think you mentioned something about learning disability health checks. So something's very important. It's part of a core access.
Do you mind if we just come back to that?
Of course,
It's an important issue, but it's one we have already looked at. So we'll only raise that if there's time.
So if I could just respond to some of those points. So our role at the LMC, and I'm a GP myself. I do my clinical work down the M11 in Essex, but my job here at the LMC is to represent every GP working in the county and their team. And we would absolutely recognise that there is a massive disparity in funding to general practice and to primary care compared to our colleagues in secondary care. It's general practice, we get less than 10% of the total pie. And with that figure, we are turning over, roughly speaking, in the county between 500,000 and 550,000 appointments per month, roughly speaking, 1 in 2 of the population. So we absolutely need to see funding move out into the community. And if work comes out to the community, funding has to follow it, because our practices are at capacity at the moment. And we would characterize the access issues for general practice actually as issues of capacity. Our GPs, despite are working very hard to meet a huge unprecedented level of patient demand. So I think we would still see, now Pam will have figures about the systems RAG ratings of practices, but at any one time in the LMC we are dealing with multiple practices that are looking incredibly vulnerable, and we have worked with Pam and Pam's predecessors to keep practices open and to try and save them. We have not always been successful, and that's a reflection of the level of challenge that we have. When I started as a GP 20 years ago, it was unheard of for practices to hand their contracts back. And we have dealt here with, in my time at the LMC, and I've been at the LMC 3 years, I've had 3 phone calls from practices saying, we need to hand our contract back. And unfortunately, one of them did. That represents a huge loss to a community. And the recruitment question that you asked is that feeds into a national trend that we have, both perversely a demand for GPs and GP underemployment, GP unemployment in many cases. That's related to the complicated way that practices are funded. We are a network of small independent businesses, or medium-sized independent businesses in some cases, who are in a monopsony. Our customer controls the price, and we can't, as a practice, if your funding for new staff explicitly excludes GPs, as the Additional Roles Reimbursement Scheme did when it started, we will then have to diversify our workforce and use the funding we can, how we can. And I could not work a day in general practice without the team around me. And diversifying general practice teams has been a practice that's brought a lot of benefit. I like the fact that my patients can see a physiotherapist directly. They can access, in some practices near me, they can access mental health support directly. But what is important to recognise is there are many things that only a GP can do. We are the Swiss Army knife of the NHS. We are the last generalists who work in the NHS. And in terms of what patients generally want and what the government promises them is they want their family doctor. What patients want is quite simple. They want to see usually the same person at a convenient time who knows them, who knows their family, who is stitched into their local community. And one of the challenges I think we have with the current paradigm shift is that watering down of the independent model of general practice, that family doctor model. And a great challenge for us is going to be how we maintain that in the face of a system and a national conversation that values a transactional model of access. Get seen that day, it doesn't matter who by. In fact, what people want, what patients tell me they want, is they want to be seeing their family doctor like they once did. And we want to make sure that we're keeping a focus on that for our practices.
I happen to know something, am I on? About the 106. So I had a meeting with our local council and our NHS estates team, and the NHS are advised every time there is a 106 plan. So they are involved, but the information that I've been given is that it is very rare for them to get the money that they are told, and they're always associated. It comes with a lot of caveats in that you can only use this money for a specific thing in this area. So for instance, in our area in March, we have huge estates problems that we've been trying to deal with the last 15 years. And whilst there has been a huge amount of building, very little of that 106 money has come anywhere near general practice. And just to support James's points about the RAG rating, in March we had 12 GP partners when I started. We are now down to 6, and 2 of those are 62. So I'd say we're red.
So we are a statutory responder to Section 106, and that exactly as Nazia says comes with caveats, but I think there is something between ourselves and your planning committees around how we get ahead of planning applications. Where I worked previously, there were subsequent 600 house builds done next to each other. And that was seen to give greater stability to build and make the supply of housing. What that does is water down our ability to actually get a sizable amount of Section 106. So some of it is about how building is commissioned and the homes and the developers and how we work with the developers. So we need to take a really targeted approach. What I would advocate for, and I've been heavily involved in Section 106 across the east of England, is an infrastructure first model. So actually we look at the local plans and we take a much more strategic view of where we have got vulnerability within practices and where we would look at expanding branch practices, where we would look at needing a new practice, and we work on that together, because that delivers the best outcome for our practices on the whole. What we have is a small pot each year, a very small pot each year for some extensions. It certainly doesn't meet up with the growth in population unless you take those opportunities to strategically plan your infrastructure with the housing offers that are being put out. So that is a very, very different way of working between the council and the ICB, and I would advocate for time spent doing that rather than chasing every small pot of 106. We don't want to let any 106 go, but actually what we want is a more strategic approach to the infrastructure. And that I have seen that done, and I'm quite happy to talk to any planning committees to enable us to have a much more rounded view of that.
Just to say, the council constitution requires me to offer a 5-minute comfort break now. So we're going to take a short break now. Apologies. To Councillor Todd Jones, who's joined us, she'll be the first speaker after we resume. So a 5-minute comfort break. Please be back on time.
Oh, was it all?
Okay, I think we're just wait for Patrick to arrive and we'll resume. Dr. Booth, I did cut you off. Is it an urgent point or could you build it into your next answer?
I think it's something that I can build in actually. I think it was just a reflection that when we are dealing with issues around new builds, looking after a patient takes a village. It's not just the building, it's who's going to be in the building, who's going to be in the community, who's supplying their drugs at the pharmacy, what's their access like to the hospital. Does that drive up certain demand? And I think there is that need to have that joined up thinking. And I think that is something that it's easily missed. It can be, I mean, for example, some practices you might have the rate limiting step for them taking on a new GP is they don't have a place to put them because their rooms are at 100% occupancy, as an example. So there is that need for granular detail. It is surprising the things that can drive your demand.
Thank you. And it also gives me a chance to say I meant no discourtesy when I introduced Dr. Uller at the beginning and didn't invite you as well. I think the fact that we've got actual GPs here talking from your perspective is a real strength of today's meeting. There's going to only be one more round, folks. So as I invite you to speak, please ask any questions that you wish to. I'm going to start with Councillor Todd Jones.
Yes, thank you, Chair, and I hope you can hear me all right. Yeah, I was really interested in the debate that was taking place just before the interval regarding developer contributions where there's a significant amount of new building happening in an area. This is happening in Cambridge City quite a lot, and the ward I represent, Arbury, has seen a lot of new development. And often when residents ask about the impact on local services and local infrastructure, including the NHS and primary care and GP practices, the answer usually from the planning section will be that it's for the NHS, for primary care, for perhaps the Integrated Care Board to decide on how the developer contribution that goes to them for that additional infrastructure is decided. So I've always wondered whether GPs, those with on the ground, so to speak, actually get any input or get any say at all about the additional infrastructure, additional services, additional buildings, or an extension to a GP practice, for example, that's been mentioned, whether any of that information gets through and whether they have any say in what's actually is developed in terms of that local infrastructure. So in terms of the Integrated Care Board and that strategic oversight and working with planning departments and planning officers about ensuring that the delivery on additional infrastructure and services is correct and it's meeting needs as a result of new development and new building. I'll be very interested to hear a little bit more about that and be more than happy to put people in touch with our own planning service here at Cambridge City Council, as I'm not that convinced that perhaps the developer contributions in this respect are being spent in the right way. That's my point. That's my point on that. Thank you, Chair.
Thank you, and you were heard very clearly. Thank you very much, Councillor Todd Jones. Councillor Dupre, I think you've got a couple of questions, as I say. Could you take them together?
Thank you very much. Yes. My first question, I think, is fairly straightforward. The focus of the report seemed to be primarily around Cambridge and South Cambridgeshire, presumably because those are recognised as high growth areas. But other parts of the county are also under pressure, and I wondered whether you had any comments about that. My second question was about the revenue funding available for practices. I'm aware that there are a number of pressures in East Cambridgeshire, which is where I am, and I represent a division in East Cambridgeshire. I'm thinking particularly of, without wanting to get parochial, Staplow Medical Centre in Soham, and also by a community land trust of a building for GPs in Streatham, where I'm not sure that there is actually a commitment from the ICB to actually ensure ongoing revenue funding for that. How much pressure is there on revenue funding to support GP practice, and how are you making how is the ICB and how are other partners making decisions about where to put revenue support for extended and new practice and provision and where not?
Thank you. I don't think it's parochial to give examples. I think you said Soham and Streatham, did you? Yes. So using those as examples, please address it. I'm sorry, I'm going to have to ask you to make notes of the replies, otherwise I'll not be able to get all the members in. Next, I go to Councillor Fane, please.
Thank you, Chair. Yes, we've heard a lot about the challenges facing GP groups, and it is, as the Chair said, extremely helpful to have if I can put it this way, actual GPs in front of us on this. And clearly the integrated neighbourhood agenda is going to put a lot of pressure on GP practices, even if we weren't seeing all these other changes, the growth and so on we talked about. But GP practices have been changing. My own GP practices, Chair, I'll follow your lead, is now 6. Used to be a small partnership of 3, now 6 GP practices, including Royston. It's very different in nature from what we used to, and this is, I think, happening elsewhere too. Now, when we look at this integrated neighbourhood agenda, we have to be thinking, are GPs actually, do they have the resources? Are they capable of delivering this? Are they actually interested in doing so, bearing in nature the changing nature of those GP practices? Or are we being unrealistic in expecting that?
Councillor Dr. Nawaz next.
Thank you. Just to follow up from my previous question, on the ratio of GPs to patients, I beg to differ, Pam. I think it is still very pertinent and it is very important metric in order to fairly critique the practices. I am fully cognizant, Chair, of the evolving practices, the ARRS, our colleague has alluded to. I'm pleased that we have 2 GPs on the panel today. And as has been said, that there is a bit of a paradox, quite a paradox, that while some GPs are being overworked, overstretched, there are those GPs who are looking for work. Now, I want to understand why that is. I think, I'm sure the 2 GPs would probably have seen this month's BMJ, which has an article in it about the GPs, about this paradox, and it, funnily enough, goes into the Central and East ICB and is quoting figures of, for example, for Milton Keynes, Luton and that sort of area, of 2,720 GPs per patients per GP, and the national figure is 2,220. Now, therein lies something that why are there not enough GPs? And these teams that we are now constituting with the physiotherapists, the pharmacists and various other ancillary healthcare workers, it's well and good. However, that is a topic for discussion on its own, so I'm not going to go into that. But I think the number of GPs or for the patients, the ratio is still pertinent. I would like to see it, please, so that each person, for example, if it is available for each town or each practice, each councillor responsible can look at their own patch in a more meaningful way. And secondly, on the section 106, again, a bit disappointed that there isn't any sort of specific information. Maybe there's a different department with the NHS, possibly the estates department, possibly a specific member person within this specific department who deals with it. It would be useful to have their input. Failing that, I wonder, Chair, if there is somewhere else we can turn to. I'm sure the County Council has a lot of data, and I know when I was pursuing the Section 106 for education, I was able to get to the actual figures. I am sure they exist. How you pursue it, whether Pam would like to take it with her, that would be fantastic. Failing that, maybe, Chair, we need, wander elsewhere. Thank you.
I think if the figures can get as far as the British Medical Journal, they can probably get as far as Cambridgeshire County Council. Councillor Maranowski.
Thank you, Chair. So the area I represent is right on the edge of Cambridgeshire, bordering Suffolk, and a lot of residents in our villages either will go to the GP in Newmarket, or there will be residents from the villages on the other side of the border coming in towards Burwell. Elsewhere, I just wondered if you might want to speak briefly about sort of cross-border working that the ICB does. Thank you.
Thank you. Councillor Martin.
Thank you very much, Chair. And just touching on something that James said, and I was surprised it doesn't feature further in the report that's in front of us around funding, and more specifically the Carr-Hill formula. Every GP that I speak to in Huntingdonshire in particular always mentions the Carr-Hill formula, and we now know that it is going to be reviewed and changed. I'm still not comfortable that it's going to make a positive difference, and we'll obviously have to wait and see what happens. But I was surprised not to see more of that in your presentation and what was coming to us. So I was wondering if you give your reflections on the changes that may be coming down and what you need to see to make it better for primary healthcare. And I think that moves to the second point, Chair, that I was going to make, that we hear about the numbers of GPs shrinking. The thing that concerns me most is that we're seeing more GPs moving to become salaried GPs rather than partner GPs, because it isn't now a profitable business for them to run, because the liability lays with them personally, not on the NHS or a larger organisation. So I was wondering if you give some reflections on that as well, please. Thank you.
And a couple of points from myself. Can I ask the two GPs and Mr. Rook, we're seeing this restructuring towards a region-wide ICB, which makes it look like power and decision-making is moving further away from the locality rather than nearer. I know that's not the intention of the people in the ICB, but nevertheless, there's got to be a fear about that. Is any of that fear justified? Sorry, I'm having to jump over some stuff. I'll just raise the issue of learning disabilities. I interrupted Mr. Rook earlier. I'll give him a chance to any of the others to come back on it. But to explain, we had a whole session on this in December. So we've had a really good look at it and had a brilliant response, as I think I said earlier, perhaps before you arrived, from the ICB, really taking on board many of the points that we looked at. And I thank them again for it. But one issue we did want to raise today to reinforce what we said last time is that many of the annual learning disability checks are being undertaken not by GPs, which is fine if everyone's happy, but we felt that there should be a right to see a GP and to have an annual health check if the person with a learning disability and or their family ask it, and we weren't assured that that was the case. And so having GPs here, it's obviously sensible for us to make that point directly to you rather than simply via the ICB. Those were all the questions.
Okay, let's go back a little bit to Councillor Dupre. So we are absolutely wanting to work with the council and with, I've forgotten the name of the developer trust. It will come back to me. In Staplow. Anyway, that information is well known to us, our estates team that are going through this restructuring process, and for my councillor colleague, we absolutely do have an estates team. I'm sure you're aware within the ICB, it will be smaller, and we are responsible for the Section 106. So we will get a list of the Section 106. It wasn't contained within the paper, but it is accessible to us. So we can share that, and we can share our strategy around developing estate. We have received lots of information and parliamentary questions from Staplow around the development of the estate there. So we recognise that Cambridgeshire is growing in line with its the relevance for levelling up within the east of England, and with that comes the economic development, comes housing. So it is a ubiquitous challenge for us as an ICB to look at the housing development across the piece. Obviously, we've got larger areas and smaller growth areas, but we need to look at the vulnerability, as you referenced in your previous question, which I don't think we've addressed. So I will quickly address that if Chairman is happy. The list of vulnerabilities that we spoke about with the RAG rating was an ICB reported determination of vulnerability based on performance, based on ageing of the workforce, based on population growth. And wherever I've ever been in an ICB or a commissioning organisation, we have always run that, because actually that's the soft intelligence. That's not about access, necessarily direct access. That's about all the other things that you know. How is the building? How old are the partners? How is the relationship with the partners? What are the population needs? And you have to build that all in to determine vulnerability. Because we have the national reporting database now that is more focused towards, as James has recognised, transactional access, we do not want to ask our practices to be doing multiple reports. So now that there is a national contracted requirement, actually we have to give a primacy to that. But that soft intelligence we use day in, day out to have interactions with our practices and support them. So I don't think don't think that's gone away. We look at the national data. We look at how many positive point movements there are and negative point movements, and on the whole we're reasonably static, but we've had a couple of practices move slightly more towards the more vulnerable space, but my team, despite going through the change that they're going through, continue to work to support practices directly. So ratios, and Nazir would probably want to talk to this, because actually we have some vulnerability within the March practice, as you've spoken about already, around the numbers of patients registered to GPs, but an outlier is determined of more than 3,500 per GP now, because of the change in the workforce. As we've talked about, it used to be below 2,000, but it is a different model now, and we only have one going up towards that level. So we will again seek to share that information with you. So
sorry, I was going to say, could that be for whole of Cambridgeshire, please?
Yes.
Thank you.
Yes.
Individual practice. That'd be fantastic.
And I will talk quickly about the Cahill formula and about cross-border working, and then I will turn to my GP colleagues around decision-making and the LD health checks, and then I think we've covered them all if I have written down things appropriately. So Cahill formula, you're absolutely right, Councillor, that has been it's been mooted for many, many years that the Cahill formula was going to change. There is work underway currently on that renegotiation of the formula that builds up underneath the that Cahill formula, and the attribution. God, I can't get my words out now, but that word that I'm trying to say. So how you put weighting on the demographics of the population versus the makeup of the staffing groups, etc., etc. So there's lots and lots of elements to the Cahill formula, and what was a position was taken here in Cambridge and Peterborough not to wait for that. So we have actually got what's called a levelling up fund. We are now changing the name of it to recognise that actually we had vulnerable practices. Now, what we've seen since that was implemented 3 years ago is that less practices have come to us asking for emergency funding, suggesting they wanted to hand their contracts back. So that information has been shared with central teams, and you will be aware that our previous Director of Finance that developed that work is working in the central team now within government around the GP offers there. That does impact directly on the revenue that you've talked about, Councillor Dupre, for a practice. It's a different conversation about the revenue for premises reimbursement, because actually that's about the square footage of a practice and what is deemed necessary for that population, and the design principles for disability access, etc., have changed since we let contracts previously. So the two things are aligned but not exactly the same. So general practice funding is a very complicated offer. It's not the same as the way that we calculate revenue for a hospital. So because it's an independent contractor model, but absolutely we are keeping tapped into the national arrangements and consultations, as our LMC colleagues and the BMA, of course. But I can give you assurance that we do have that fund locally, which is not typical of ICBs across the country. It is an enhancement to GP funding.
So yes, I think it's a good example of the fact that the Cahill formula doesn't work, that we have needed and have been grateful for the levelling up funding locally. Now, I should caveat this, I'm, as well as being the LMC's medical director, I've just finished my tenure as the contracts and policy lead at the BMA's GP committee. I'll be there on Thursday talking about our new contract offer, where my colleague who's just taken over for me is going to be having a headache all day. I have to say I'm not disappointed. That's no longer me. In terms of the GP figures, and Pam will have more accurate ones, but the figures that we have from one of the GP trade press tracks this as well. So Cambridge City, you're looking at about 2,025 patients per GP. Fenland, roughly 2,596 per GP. South Peterborough, 2,320. So we are seeing definitely a significant uptick in all those numbers. Now, that is a national trend, and in lines with national trend, areas that have higher deprivation are widening further. And much as I'm going to respectfully disagree slightly with Pam here, that I still think that is a key metric. And the reason for that is fundamentally the oversight, the responsibility sits with the GPs in that surgery. And an even bigger metric, which we don't count well enough, is partner capacity per population of patients. And that, I think, ties in a little bit to the question that Councillor Fain asked about your practice doing what a lot of practices have done, which is the small local practice becoming part of a big conglomerate. My own practice, I was forced to do that. Now, this is in Chelmsford. It's not here in Cambs, but I started off my career in a practice with me and my dad as the partners, 2 salaried GPs, 2 nurses, about 6,000 patients. We knew everyone on the estate, they knew us. It was the model people wanted. When I left partnership, it was a 3-site, 25,000 patient practice. It's now taken on 2 more practices. Taken on 1 more and 1 more in the offing. I beg your pardon. The reason for that is the 3 small partnerships, including mine, that came together, we weren't sustainable as individual practices anymore. The money just didn't work. And that's related to both how our funding formula works, but also to the unusual partnership model that GPs have to have, which is, as I'm sure you know, we are about the only professionals who have to work under the terms of the 1890 Partnership Act. I have to form an unlimited liability partnership if I am going into partnership with other GPs. The core GP contract insists upon it. And what that means is if your money is running out as a GP, the reason we don't contribute to the NHS deficit is we have to wipe our own face every year. If I have a financial hole, as I did have through a property issue, that's my house, my children's well-being under threat. I don't have a deficit that, say, for example, Addenbrooke's can have written off. So that's why it looks different. And I think that feeds into the question about, do we have the resources and the appetite for this new model? And I think the truth is that if you asked most GPs would want to work in the old-fashioned way. Most of us became GPs to see our patients, not to be business people. And we want to work in a sustainable model with a smallish practice where you know your patients and you have that continuity and you can build your services around that population. I knew what my patients needed because I knew them very well. So where we are now, there are, as with any change, there are opportunities and threats. And I think there are real opportunities for the neighbourhood model. We have GPs, including Nazia here, who are very forward-thinking, who will look at innovative models. There are always ways you can improve patient care. But equally well, I think this does represent risks to the autonomy of the individual practice, and that has been a strength of general practice. I think there is a risk in, for example, IHOs, which have to be led by trusts, not by GPs. There is a dilution and a weakening of the GP voice in these plans. So I think that's an IHO is independent health organisations. That's a trust. Sorry, this is the equivalent to your doctor talking lots of acronyms at you and assuming
the IHOs that I was struggling with.
Yeah, so
tell you what an IHO is.
So integrated health organisation, which is this idea of you have the one, but popular in America initially, this one body led by a hospital trust that's running this sort of vertically integrated model. Most GPs are quite wary of being employed by hospital trusts because what we don't want is the unique work we do to be moved gradually into, not to put too fine a point on it, solving the trust's problems for it. You know, we reflected earlier on the long waiting times for an autism assessment. Hospital waiting times for outpatient appointments are all really long at the moment. And people get worried when they can't see their GP within a day or two. What I don't want is the referral management work pushing lots of unfunded work out into general practice. So we're just effectively washing the hospital's face for it. And that's perhaps a little bit of a deliberately provocative statement. But so I think there is a very varied appetite around this. There is a lot of nervousness around change. And I think it's worth reflecting that the Darcy report, so Lord Darcy commissioned a report on general practice because, of course, the best person to write about the problems of general practice is a highly specialised surgeon who works with robots. But actually, he did say one very sensible thing, which is the agenda for over a decade has been moving care into the community, to move patient care closer to it. And we haven't achieved it. The funding has always gone into big trusts. It's not gone out into the community. And it is very hard to have, and we find this at the LMC, that we represent all our practices, but you are sitting at tables with the CEO of Addenbrooke's, and you think about the budget and the influence that that budget brings. It's quite hard to have that influential voice. And this model doesn't strengthen that. in my view.
I think what is being said here is incredibly interesting, but I'm also having to look at the time.
Yeah, I'm so sorry.
And I do want Dr. Uller and Mr. Rook to have some final words.
Yeah, absolutely.
So just to comment on the ICB getting bigger, and obviously the significant loss of commissioning capacity that comes with as a result of national decisions, which I'm sure we will come to regret. In terms of will that make decision making further away? Well, I don't think so. I think the absolute intent is to come back to James's point about it takes a village to support a population, and that's the intent of the neighbourhood. So some of the things we will be trying to solve there are very particular local issues about have we immunised our children, have we got a cancer screening right, have we responded to the points Health Watch have raised around GP access, is that getting better, have we resolved dental access in your local area? Those are the things that we want to fix in a neighbourhood and can only fix really by engaging and supporting people in their local area. So I think the national policy, while the ICBs are changing, is very much about subsidiarity. And I think one of the crucial success factors of that is the agility and ambition of general practice at the core of that, because we proved that we can grow and develop a workforce rapidly, we can outreach, we can solve public health issues with and through that model in a way that it's harder to do with bigger entities such as hospitals and others, because they just don't have the agility, and that's been our experience. And I think that's what Lord Darcy was calling out. So that's the intention of the neighbourhood, is good access, but also equity of access to core services, but also being able to find and support vulnerable people in the neighbourhood. And that's really what this is about. And I think the crux of that is going to be not shunting work, but planning and delivering more localised care with and through partners in the neighbourhood. Some of that's about estates planning, but some of it is crucially about connection of staff and development of roles or restoring roles that we've lost over the past couple of years, like the number of people who support vulnerable people in social work, number of community nurses I alluded to earlier. That's the infrastructure we want to build in and around the neighbourhoods to support this agenda.
Me left. Does general practice have the appetite for it? I think James is right. Some of us maybe, but a lot of us are really scared of this change. I think fundamentally we have got neighbourhood centres. They are general practice centres. They are GP surgeries. And a lot of this work is already being done, but we are not invested in properly. And you think, well, as a starting point, shouldn't we be building on what we already have and strengthening that to receive it, to receive the future plan? I think one big worry is that the trusts come in and take over general practice or dictate what we do in neighbourhoods. We won't have the same efficiencies. You won't get people who know their patients. You'll have people who do a job. At the moment, you know, I do 12-hour days. I am a jobbing GP. I have got a small list size. They know me. They may not like me, but I've been there for 12 years. And, you know, I know them. I know the children. I know the parents. But we have had to adapt to so many things over the last years. And the fact that we are small, the fact that we are agile means that we can do it. And so general practice is definitely the right building block for a neighbourhood to be built around. But we need to have that extra support to be able to do it. We don't have the infrastructure. I cannot employ another doctor because if I do, I will have to go and sit and work in my car. There is no space in our buildings. So there's lots of basic stuff that can be fixed without having a big, massive plan to overhaul everything. In terms of learning disability checks, I would hope that nobody is refusing a learning disability check with a doctor if somebody is asking for one. And so if they are, I think perhaps we can take that to our GP committee to discuss to make sure that that's not happening in Cambridgeshire. They are done by other professionals because we just capacity, we need to have that done. But, you know, I can't imagine refusing a check if somebody's asked for it.
Thank you. It's been incredibly interesting. You've also been incredibly candid with us, for which we thank you. And it's led to a really constructive, what I see as a really constructive exchange. Our usual practice is I sum up from some of what I've heard. That's then compared by our committee secretariat with the notes that she's taken, and that is turned into the formal recommendations. I think we've heard today that there's welcome from the point of view of our health partners of the direction of travel, but a huge question about whether it's being adequately resourced. We had a lot of discussion about population growth and housing developments, which of course are high in terms of the next period in Cambridgeshire. I think we heard that there's a shortfall of Section 106 money actually getting through to fund the development of health centres. We heard, I think, a very cogent argument for an infrastructure first approach, a strategic approach, working with local plans. I think we'd want to support that and to agree with it. But I think we also heard that there's some worry about joined up thinking and the whether, even if money is going into buildings, whether the revenue is available to employ the people that are needed to populate those buildings. So we had a long discussion about those issues. We had lots of interesting discussion about data and Pam promised to share more data from the performance database, GP performance database, and about the workforce. We did hear in that example that GPs in Finland have gone down from 12 to 6, just that example, and one must express concern about that. And also the points raised by Councillor Dr. Nawaz about GP underemployment and unemployment despite our needs, and many of those are connected, we understand, with the funding formula, but it's proper for us to express our concern about that, I think. In terms of the pace of change of resources being pushed into neighbourhoods rather than into the acutes, what we heard is flat cash to hospitals, and then that money needing to be reinvested to neighbourhood-based care. And we'll see where we get after 9 years. I think Mr. Root was being honest with us about that, but I think we all know that would not be the scale of change that many who support the neighbourhood model would want to see. And I think perhaps we would be recommending that you work out what's needed at the local level and then take decisions to shift money there, not just skim some money off the top from the acutes and reinvest what's there. We heard from Councillor Dupre about the challenges of keeping practices open. Thank you to Pam again for also responding to that in terms of the soft data, and we would join you in expressing concern about 2 extra practices that are vulnerable. But I think we probably want to welcome the Levelling Up Fund, because that has been clearly one way of trying to address that. The additional roles reimbursement scheme has excluded GPs. That seems to have both advantages and disadvantages. There's been excellent diversification of the workforce, but perhaps not more GPs. So I think we'd want to note that probably. When our GP colleagues talk about the importance of the family doctor, I think this committee and this council would underline that and strongly support that. And although we only dealt with it briefly, I think we'd want to acknowledge the improvements there have been on access. Clearly there's more to do, but I think, you know, it's very important in these sessions to recognise where efforts for change have taken place and do produce results, and that would be one area that we would point to that. With greatest respect to the difference of opinion even within the guests, I think, again, Councillor Dr. Nawaz, but this committee would say that there should be maintained relevance and attention to the ratio of patients to GPs, we would express concern about the uptick in those numbers, particularly in deprived areas, and ask for full data to be shared by that. Having worked out that IHOs refer to integrated health organisations, that vertical organisation that was talked about there is a source of concern to this council, as well as to those who have come and talked to us. I think we would support those of you that gave evidence about the importance of autonomy of GPs and of building on the strengths of what we have. I think those were all good points made by colleagues and that we would want to endorse. On ICB restructuring, we heard about from the ICP about the importance of subsidiarity and the genuine hope that decisions will maintain in being as local as possible, and we would want to welcome but also carry on watching that to make sure it really does happen. And on the right of people with learning disabilities to actually see a GP for their annual health check if they choose, you've made a commitment to take that back to the GPs forum in the county, and we're extremely grateful to you for doing that. Anything you need clarifying there, Rashenda? Any members want to say something that haven't heard me say? Yes, Councillor Malinowski.
Just that we sort of left out the cross-border GP working. I just wondered if there was a chance just to get a little bit conscious of time, but a little bit of a line on that.
Yeah, thank you,
Please.
Councillor. That was what I wanted to come in on, actually. So there's a very long relationship between borders of commissioning organisations, and we're already looking at that Uttlesford area and as an example, for us to be able to say, how do we link in with other areas around this geography to enable GPs to work across the footprints. So we can come back. I can work with you specifically. I used to work with the Suffolk colleagues, so I know them very, very well. So if we want to connect those links together, it links into our place teams, but we have to respect patient flow. So patients will flow to other hospitals. They always have, irrespective of what national boundaries have been put into commissioning organisations. So I can assure you we're very used to dealing with that, and we will allow that freedom to continue.
When the local area extends to Milton Keynes and Luton, it'll be difficult to leave the area to go to a hospital. I think our conclusion there is that we encourage continued attention to the cross-border issues, and that you've kindly offered to share some more information with us going into the future. Okay, as I say, I found that one of the most interesting exchanges we've had and most important exchanges we've had. We hope you found the dialogue interesting, and we hope that as we produce our recommendations, they'll be helpful to you. Thank you very, very much for attending.
Mr. Chairman, do you wish me to stay for Health Watch's report or leave?
You're very, very welcome to stay, but it's the rest of the business is mainly organisational, so you may find it less than
I'll leave it.
A bit less.
I'll take my leave
than what you have, but you are welcome to stay, as are all members of the public, of course. Right, I'm going to move quickly on to the Draft Health Scrutiny Committee annual report, which is on pages 45 to 68. We'll take this to full council in July. Rashenda, did you want to say anything in introduction?
I think just very briefly, Chair, it's following very much the same format as previous years. I think, as we mentioned earlier, there have been some very constructive responses received to the committee's recommendations in recent weeks, and obviously there are additional ones that have been received that we haven't yet had a chance to look at. So I think it would be good to reflect those in the report to actually see the difference and the impact that scrutiny is having. This is very much the committee's report to full council. So please, any changes or additions that you want to make is entirely for the committee, and we will reflect that. Thank you, Chair.
Thank you. Any comments today? I think we've had a fascinating session today, so I think adding those details in will also be really good for the report. Any comments from members? You happy? They're happy? That's noted. Thank you very, very much. We now move to the quality accounts. So I think people generally have been here last year, so we'll understand, but I'll just summarise it. Quality accounts are not the financial accounts of health bodies in the county. They're quality, the quality of the different health units bring us reports on the quality of their work, and then we get a chance to comment on them. And that's a statutory duty of the authority. They always come at very short notice. And so the danger over the years for us as a council was that we didn't get our act together in time, and the different health bodies published their quality reports without input from us. And so for the last two years or so, what we've done is set up task and finish groups, which can meet at shorter notice, make input fairly quickly, and then we can make, and they have delegated functions to, I don't know whether there's consultation of some kind, but subject to any consultation needs, that then they are sent as this council's input. And I'm hoping that each and every one of the members here is going to volunteer for one of those 3 task and finish groups, which will enable us to have a decent one for each. Rashenda, could you say how we're going to, I think, organise which task and finish groups do which health bodies?
Yes, thank you, Chair. So we're recommending 3 task and finish groups, as the Chair said this time. So each of those groups would look at the quality account for 2 local trusts. So we're proposing to group those as follows. 2 acute trusts together, which would be Cambridge University Hospitals, which is Addenbrooke's and the Rosie, combined with or alongside North West Anglia, which is Hinchingbrook Hospital. Then a second group looking at non-acute trusts, which would be Cambridgeshire Community Services and CPFT. And then a third group, which would be the East of England Ambulance Service and Royal Papworth Hospital, because obviously as an acute, it's slightly different because it has a national remit.
So colloquially, the first one is Addenbrooke's and Hinchingbrook. The second one is the Community Service Trust, CCS and CPFT. And the third one is Papworth and East of England Ambulance Service. So I'm going to ask everyone, please, to volunteer for one of them, starting with Councillor Dr. Nawaz.
Thank you. I'd go for CCS.
Councillor Martin. Hinchingbrook one, yeah. Councillor Malinowski.
Addenbrooke's.
Don't everyone go for Addenbrooke. I'm not criticising you at all, but not everyone, please go for Addenbrooke. So it's obviously of interest to lots of us. Councillor Kane.
Can I just check, as the appointed governor for CPFT, should I not go for that or should I go for that?
No, we would invite you to go for that if you're willing.
Then I'm happy to be on that one.
Yeah, great. I'm looking for particularly the ambulance and Papworth from Councillor Dupre. Councillor Garvey, are you up for that? Well done. Councillor Garvey?
I'm up for re-election in 2 months, so I don't know whether you want me to join.
I do want you to volunteer, and then assuming that you're there, we would very much like you to take part.
So what's left?
Are you happy with the third one, the ambulance and Papworth? Yeah?
Yes. Yeah.
Thank you. And Councillor Kane and myself will distribute ourselves probably between the first 2. Any strong wishes?
I'll go wherever I'm needed, Chair.
I think on this occasion I'll go for CCS and CPFT, and Councillor Fane will go for the 2 acutes. Okay. For Addenbrooke's and Hinchingbrook, Councillor Fane. for anyone who's given an apology, and also I think we've lost Councillor Todd Jones. If Rashenda, I'm sure you could email them and ask if they're willing to join. Oh, God. Thank you. I'm sorry, Keith. You're such a shrinking violet in this room that I overlooked you. I do deeply apologise. Of course, that's really great. And they've got really difficult challenges. So I think it'll be a really interesting piece of work. That Councillor Todd Jones has rejoined us, right? Do you, all of them are open, Councillor Todd Jones. I think we've got reasonable numbers in all of them. So which one would you like to choose?
Well, I think it would be helpful if I was in Edinburgh, because I'm already an appointed governor there, so it would dovetail nicely with that role.
Yes, and we do welcome that. Just to say to Councillor, as I said to Councillor Kane, it's sensible for the governors to be invited. So, for example, Councillor Sanderson, who was with us earlier, will be invited to the Hinchinbrook one. Okay, thank you very much, everyone, for volunteering. And the meetings only take place for an hour online, so please make every effort when they're called to join it, if at all possible, to make the whole system work. And it does put quite a pressure on Rashenda. So on behalf of the committee, we thank you for your input into all of that, work. We've now done. We've done quality accounts. We are nearly there, folks. There are, on the formal paper, it's got 5 recommendations on the quality accounts, but I think we've dealt with those unless anyone wants that clarified at all. No, so they're taken as agreed. Which brings us to I think the final substantive item, which is the work programme. So Councillor Fane and myself got together and we looked at the various suggestions, and with the officers we've slotted those in, not for the full municipal year but for the rest of the calendar year. But there's a long list of possible suggestions. They've been graded by Rashenda using a methodology to help identify which are the most pertinent for us to address. And so we are here to listen to comments. If people feel items are not included that should be, we're absolutely here to listen to that. And so we'll hear that, and then we'll meet together again in a chair and vice chair meeting to make any amendments to the forthcoming programme. I'm going to suggest at the moment we don't go beyond the calendar year, but we'll see what people have got to say. Can I take any comments on the work programme? It looks like you're happy with it. I'm seeing nods, so that's great. The one thing that we said earlier is NWAFT will have to be added somewhere, and we'll see what the acute trust come back with on business continuity. Did I cover that earlier or not? No, I didn't. Sorry. After an exchange with the chief executive, he, and I think he was right, was very concerned at the fire that took place in the car park at Addenbrooks at the end of last year. Not the fire in the cars, but the fact that it made such a big impact on activity within Addenbrooks Hospital. And he was concerned that he suggested that we use our health scrutiny function to ask each of the acute hospital trusts what their business continuity plans were for just such cases, because many organisations, including this council, have plans in place if such events happen. And I think there was a concern that Addenbrooks didn't, and maybe the others don't. What we did then was to write out to each of the acute hospital trusts. And so just as we did with NWAF, we'll see what they come back with and see whether that then merits possible scrutiny. So we'll come back to you on that. But I do want to note in the context of the meeting that activity has happened, so that you're aware of it. Okay, I think we've agreed the work programme and the and the future agenda. Any other business that I've missed or that anyone wants to raise? Yes, please, Councillor Kane.
I just wanted to formally say thank you to Agenda for organising our site visit to CPFT. It was really useful, and thank you very much. It was really, really well organised.
You're absolutely right, but also I want to thank you and Councillor Horgan and Councillor Garvey for taking part in that visit, and I think we learned a lot from it. I think it was a very good exchange. It was different from having an exchange here, and I would commend other members when those opportunities come up in the future to take part in such site visits.
Can we get copies of the photos that are taken?
He wants his photo. It's coming. All right. Okay. And I'm sure we'll all look lovely in the photo that we took at the start of today's session. Okay, I'm not seeing any other hands, so thank you everyone for another, what I think has been really excellent session. Thank you for all the effort and work you've put in, and I formally close the meeting.